Okay, welcome to Dark Jedi. I'm here with Steve Turner, and all his details will be up on the screen now by Martin. I'm Dominic Stenning. Let's have a chat, Steve. I always try and avoid using the term interview because I just think it's nicer just to have a chat. Interview
Yeah, I
implies
agree.
a power relation, doesn't it? So let's just have a chat. So yeah, we agreed to have a chat about four topics, haven't we? So patient-led care, truth in healthcare. Well, actually, let's just go through them as we go. Okay, so what does patient-led care mean to you, Steve?
Well, to me, I mean, my background is general and mental health nursing, and it's quite an unusual background. I've been self-employed as a nurse since 2008, so I've been doing all sorts of jobs, and it's a term that I've coined because I believe it's the way we should be working. You hear a lot about shared decision making, and I'm a nurse prescriber, I actually teach on the course. I used to use this, and I still use the term shared decision making, but the more I think about it, the more I think this is an outdated term. I'll
Mm,
meet with a patient and I'll talk about, I mean, mostly what I do is medicines now. So we talk about medicines, but it could have been in my work as a mental health clinician. I see the clinician's roles as to give patients options and provide information. And yes, when you meet with somebody, you can come to a shared decision, but ultimately it's the patient's decision. I think the easiest example, if I could give, is prescribing. I would say to somebody, these are the options for medicines, try that one. But the patient might go away and find it's really not working for them. And
yes. Well,
it's the patient's decision. It's in and there's even guidance that says this should be the patient's decision. There's nice guidance
really.
on
You
medicine
see,
adherence.
I, I did have a really good experience. It was with a relative of mine. And I went along, and it was really refreshing. And the psychiatrist goes, well, look, antidepressants, they're very hit and miss. There's a lot of evidence that they don't work. So we'll let you pick one. And I was like blown away by that because, yeah, he let us pick one, which we did. Bit of a long story, but yeah, he let us pick it, which was really refreshing and new. I think there's often this approach of, I'm the doctor, I will decide what you should have and need. And I think that can lead to patients. I think there was a study that something like 65% of patients lie to their GP because they're too scared to tell the truth. And I think a lot of that's down to this power dynamic where, yeah, shared decision making is talked about, but I don't think it's really believed. It's just a bit of a buzzword, isn't it?
There is a power dynamic, and I've learned sometimes the hard way that sometimes when you're having a conversation with a patient, I'm talking as a nurse, as a clinician now, you want to do the best thing for the patient, and you might end up being a bit too directive. But actually, prescribing antidepressants is a good example. There's loads of antidepressants. There isn't a lot of evidence that any one is better than any other one. Some of them work, you can see it works slightly better in certain circumstances, but it is down to giving the patient all the information about what where they're potentially good, what the side effects might be, including the option not to take any at all. And that is the way now. That is, I teach on the prescribing course for nurse and pharmacist and allied health professional prescribers, and it's the same training that all prescribers of medicines have, and it is all about giving the patient the choice. There are a few examples where something is really in other areas quite where some medicine is really, this is the one that's proven to work better, but in mental health, particularly around depression and also bipolar disorder and several other illnesses, there isn't a huge amount of evidence that one is better than the other.
It's interesting you say that. Apologies if everyone could hear a bit of rumbling in the background. The bin men have now finally gone, which is great timing. Um, Yes, so I know lots of people with various mental health diagnoses, including bipolar, and I know the side effects to a lot of these meds can be pretty serious. Shaking hands to the point, I know one friend who struggles to even sign his name at times because of his handshakes. But I do know that that friends that they found the right drug for them, and they know what's the right drug for them because they know how it affects them. So it makes sense for it to be patient led, doesn't it? I think.
And it doesn't always relate directly to the guidelines, especially as a lot of people, particularly as people get older, have more than one illness. So if you're taking more than one medicine, they're going to interact with each other. So
Yeah.
if you follow strictly the guideline for each individual medicine, that might not be the way forward. I've worked with a lot of people where they're on a little bit of an unusual combination of medicines, but they've proven through trying other things, through trying to come off it, through stopping taking some and taking others, that this is what works for them. And that's what's important. It's what works for the individual, as long as it's safe.
Well, exactly. It's what works for the individual. Otherwise, that individual is probably not going to use that medication as is intended, or it's just going to be wasted. So it makes no sense to me. Yes, there are some medications, I think, that some controlled medications, which I think we're coming to a bit later. But I would even argue then that as long as the risks are explained and the person meets a certain criteria, then it should absolutely be their decision. But we'll get to that a bit later. Yeah, cool.
On side effects as well, I think it's really important that clinicians have a full conversation with people about side effects. And it's not that you're going to necessarily get the side effects, but you need to know what the common ones are, and you need to know where to find that information. And people need to know. I'm doing a course with patients at the moment about medicines, a short course, and a number of short courses. And you might have something about your individual makeup that means you have a side effect that's not listed or not listed high up in the British National Formulary. So you might have an unusual side effect, and people need to know and be aware of that. And then you can balance out, is this medicine doing what I want it and I can put up with the side effects, or are the side effects actually worse than not taking it?
Well, that's it. I mean, and I think that's going to be the interesting one, because everybody does react differently to medications. In the previous video I did with my mother, how I reacted to SSRIs. I think it was probably more of a reaction to me coming off the amitriptyline than it was me, the SSRIs. But yeah, absolutely, everybody's different, and I think that's another reason for that having to be patient-led.
Yeah.
I mean, I suppose around patient-led care, I think there's a difference between patient-led care, self-management, and that. And I suppose a lot of what the work I do, which is working in healthcare with patient leadership, it is different. It's not the same as sort of personal care. But that's a whole new topic in itself. That. Okay, so let's move on to. I mean, is there any more you wanted to add around patient-led care?
I suppose that the other thing I would say is it's a term I use, but I haven't invented a new way of working. I draw on all the best practice from everywhere, and basically, if it works for you and it's safe, that's what I mean by patient-led care. It isn't a whole new way of working, and it isn't the opposite of shared decision making. It's just really acknowledging, for us clinicians, which sometimes we're a bit difficult to let go of things because you want to look after somebody, that it is the patient's decision at the end of the day.
Yeah, and I think that's the culture shift that needs to happen, is the healthcare professionals sort of realizing that, they've got to. I think you gave me a great quote, didn't you, earlier? Of course, I won't be able to remember it now, but we'll put it in the description.
We'll find it.
Yeah, we'll find it. Which makes the point that, you might have 6 years at medical training school, but I've had 20 years living with whatever condition it might be. And I know my body, I've been in it for, I won't say how many years, I've given away my age, but good 40 years now. So yeah, absolutely, it has to be patient-led, obviously within reason, but I'm a firm believer that we're all sovereign adults and we can make our own decisions, and we should be able to decide what we're putting into our bodies.
Yes.
And I really, really believe that there's so much medication that gets wasted or not used properly because of the way it's prescribed and the patient's not fully comfortable with it.
The official Department of Health figure that they use now, and it's gone up over the years, is that 50% of people don't take medicines as prescribed. That's based on a range of studies, and a lot of them were around medicines that were returned to pharmacies. So I think most people and most clinicians accept that that's definitely an underestimate, because what about the medicines that people actually do get, but they don't take? I've worked with people who've not taken the medicine that I've prescribed for them for years before they trusted me enough to tell me. And I've done it myself. This is not about a particular type of illness. I've had a prescription from a doctor. I've looked at it and thought, well, I'm not going to take that. I just walked out and just didn't cash it in and never told anybody. So
I'll own up to us with we're owning up. I've done that too. I've my own little stockpile, but you know, I think that's kind of natural, but that also comes from a place of fear as well. Because if you don't have control over your medications, I think it's only natural that you stockpile certain medications, because you're scared that if you do need it, you won't have it because the doctor might not give it to you. And another reason why I think patient-led care is so important. But I hope my doctor's not watching this. Anyway, so I suppose we can come back to patient-led care as we go on. I'd like to do this one of the topics you want to talk about, which was truth in healthcare. So what do you mean by when you say truth in healthcare?
Well, in my career, I do my teaching sort of borders on ethics. I'm not an expert on ethics, but I do teach about lessons learned and talk about areas of malpractice and duty of candor, which is the duty to tell the truth. And I'm particularly focus on the Robbie Powell case, which was the case which is in 1990 that Robbie Powell died. That was the case that identified that in law, it says a doctor, but I take this to mean all clinicians, nurses, everybody. In law, a doctor does not have a legal duty to tell the truth. European Court of Human Rights ruling. So you've got an ethical duty, you've got a duty to your professional body, you've got a duty to the patient.
Yeah.
There is not actually a law against it. There is a duty of candor that was brought in recently, where there is a duty for the organisation to tell the truth to patients. That's slightly different.
Yeah, I've seen that.
It's a worrying subject for clinicians, and it's people worry about what's going to happen. Am I going to be sued? But I just, and it's also, it's not totally straightforward. I think you've seen one of the videos I did with Sam, who I teach with, and he asked me, do I always tell the truth? And
yeah, he put you on the spot there. And,
yeah, we sort of a bit of a put up job because we wanted to talk about it, because when you're working with sometimes you might sort of, this is from a clinician, that you might sort of gloss over something because you really want somebody to take up this treatment or medicine, and you might, and I have certainly done that. I've always regretted it. It's better to be honest. But the other area of duty of candor, which is the one that there's a lot of the media focus on, was on if something goes wrong. The organisation has a duty to tell the truth to patients, and now organisations have been prosecuted for not doing it.
Right. Well,
that is
a few things, because we had leaflets coming round, you know, with saying, you know, duty of candor, which is the corporate, you know, I know the person corporate affair, you know, corporate directorate was in charge of all that, which I found interesting. But I didn't know that about the law with doctors. And I also know it gets a bit tricky, doesn't it, with, well, I was told with mental health that it's different with mental health, that they don't have to release all your records, that they can hold stuff back if they deem it as to damage your mental health.
It's interesting that, because I would dispute that. I've had conversations on social media about that. Yeah, if you're dealing with somebody with a mental illness and there's a safeguarding issue and they've asked for their notes, you can go through the notes and say, this would cause a safety issue, but it has to be something very specific. You have to say this certain bit of information would cause the patient too much distress, or there must be a really good reason. Third-party information, so somebody's written a letter about somebody else, if you ask for your notes, that is always taken out. Yeah, there's often a lack of clarity about what is and what isn't third-party information.
Right.
But I find there's very, very rare occasions when anything should be included, and I actually am a very strong advocate that consultations should be recorded. and I do mental capacity assessments now.
I've not even thought about that, but that's a good one. I'm sure there'll be loads. I know what it's like just getting the NHS to get on video chats, the whole security thing and privacy and that. But yeah, I agree with you. I think that's a good idea because it protects the healthcare professional as well.
It does. I mean, it has its roots in the no decision about me without me stuff that came out years ago. And whenever you see a clinician, you should get a full copy of the letter, the clinic letter, which people do get now. And it's just an extension of that, really. So you've discussed all this with people, you put it in the letter, you haven't just sent it to their GP, you've sent it to the patient as well. Why not record it? In my mental capacity assessments, and I do some individual medicines reviews now, I'm just about to start saying to people, would you like to record it? Go ahead.
And I think that's really good if they have the choice, because I know I have a terrible memory, and I certainly couldn't remember some consultation I had, say, a year ago, 2 years ago. And actually, for me, watching that back might actually help me in my own recovery.
And it would help us as clinicians to see, have we explained things fully? Because we all come away from a consultation, whether you're the person who's seeing the patient or whether you're the patient, with a specific memory of what was important about that. But I would be interested to watch some of my consultations and see whether my memory was the same. And I can't, if you're trying to do your best for the patient and you're open and honest, I can't see a problem with that. I'm going to start with my mental capacity assessments. I used to record some of them, but not all, if I thought it was relatively straightforward, to say to the patient or their deputy or attorney or whoever's got power of attorney for them, do you want to record this? I'm happy for you to do it.
And just quickly, just to describe medical capacity, just for anybody watching that might not know.
If the Mental Capacity Act there's sometimes not a full understanding of mental capacity. Mental Capacity Act defines mental capacity. It's about a specific decision for a certain thing. So as a clinician, I used to read people's notes and you'd say, this patient doesn't have capacity. That is meaningless in law. It's what doesn't this person have capacity to make a decision about? How has that been assessed? Have you assumed to start with that the person does have capacity and work back from there? Have you had an independent assessment of it? But it's always decision and time specific.
So you have to evidence that decision on what it is and why. And then do you need someone else then to overlook that as well, or is that enough?
Which should be, if it's, say, happening in a hospital, it should be a team-based decision. It should be based on a multidisciplinary team decision. And also, does somebody else have capacity for that person? Because if you are worried, this is really important, and something I'm going to do is, I'm getting on now, and that's something I'm going to do. I'm going to do a lasting power of attorney. So I will give somebody power of attorney to look after, there's two types, there's finance and there's health and well-being. So you authorize under lasting power of attorney, somebody can look after your health and welfare and make decisions for you, and can look after your finance and make decisions for you if you lose capacity. So a lasting power of attorney is, you do it when you're well.
Yes, that sounds really interesting. I didn't know it was split into the two like that. I think that's interesting. I don't think people think about this. It's at any age. I mean, especially I'm 42, so I could have a stroke. I could have something happen to me. I might not be able to speak. I might not be able to think right. So, these things can happen. Nobody wants to think about it, but.
And if you've got very strong views about what you want to happen, you can, through the lasting power of attorney process, which is a legal process, and you have to have a capacity assessment to get to it's an appointee, right, to get somebody appointed to look after your capacity. If that doesn't happen, and you have a relative who doesn't have capacity, either for health, for dealing with their health and welfare, or dealing for their finances, you can apply to the Court of Protection for a thing called a deputyship.
Right. Okay.
So they would be assessed as to whether or not they had capacity for these specific decisions you were worried about.
Right.
And if you're an appropriate person to do that, you can then become a deputy and make decisions.
Okay, I'm learning something new here. This is
it's really something that everybody should think about before it actually happens. Would you like, is there something you really trust who you would like to make decisions for you, or are you happy to rely on the medical team to make a best interest decision.
Mm. Yeah, which I know a few people that'd be very uncomfortable about that, and probably would. I mean, and I actually think if you're very, what's the word? If you're very much, know yourself, know your own decisions, and very much focused like that, actually, you really should think about doing one of those. Really, if that's the type of person you are. I always am a bit reliant on my next of kin. But I think as I get older, I suppose I really should think about doing what you've done. So
if you haven't done it, the next of kin, best practice, they should be consulted. But often these are emergency situations and really critical situations, but the next of kin doesn't have the power to make a decision for the relative. So when my dad was in hospital, he broke his hip, he was getting really old, and he had dementia, and my brother was in hospital with him. This was up country, I wasn't there. And they asked my brother what would like to happen, but I had to explain to my brother that it is you haven't got power of attorney, because he was really worried. I've got to make a decision for my dad. What do I do? And I said, no, you can leave it to the medical team. You can just give them your opinion.
Okay, that's interesting, and I suppose that comes back down to shared decision making with the team. Because to somewhat, I know the shared decision making lost a bit of work, but it is important because that is a shared decision. Because you need to be able to discuss it equally, certainly as equals. But then again, you should be, I know I'd want my relative to lead on that. Ultimately, the decision needs to be with the patient or that patient's representative. Yeah, it wouldn't fit well with me. Shared decision making implies that it's equal, and therefore the doctor could overrule, sort of had the casting vote, as they would say. So yeah, actually, I'm more for patient-led. And I remember years ago, people would sort of laugh at me for talking about shared decision making, let alone patient-led care. I think that can be quite a hard concept for a lot of people to get their heads around, especially older generation. But it does feel like we're moving into a different sort of era, different direction.
And I work with a lot of people in all sort of fields of medicine and nursing and that, who this is their view now. This is about the patient's decision. Obviously, there are critical situations when something might have to be done.
Absolutely.
At that minute.
Yeah.
But then when the patient regains capacity, it is about what the person wants.
Yeah, absolutely. And hopefully they do regain capacity as well. Okay, so truth in healthcare. We've sort of covered that. Is there any more you want to add on that?
I suppose as well, it is difficult. I've made mistakes. Well, I've actually done a podcast with Sam about mistakes, and we talked about some in detail, but it is quite hard. I've made mistakes. More recently, I made a mistake. And what happened is I told the patient I made a mistake, got a second opinion there and then, gave the patient all my details and said, and your first thing is establish whether you made a mistake that's going to harm somebody.
So there's a level, a gradient of that.
Well, so, yeah, it's with what you see in front of it. What's the harm? Is there going to be a harm? Do something about that first. No harm was likely, but it was a mistake. Now, I've trained years ago, and it certainly wasn't the practice in hospitals to tell people that a mistake had been made if no harm had been done, even if it was a potentially bad mistake that people could learn from. And that has changed, and the culture has changed. And patients,
I do hope so on that. I just get a bit more skeptical because I know how easy it is for. I suppose I've got right in my head right now is James Titcombe with his son Joshua and what happened there. So I know there's this culture where every ranks can close and look after each other, and I get that. But that definitely needs to change. I mean, and I do think that things are changing. But yeah, it's a hard one for me. How do you know when everything's changed? How do you know it? When is it consistent? I know we had a bit of a chat going on social media about this, is having some consistency. I know I was mentioning, if McDonald's can get a burger and chips consistently right around the world, maybe we can do the same with care and also the culture and the rules around that.
And there are some high-profile cases. Joshua Titchcombe, Robbie Powell. There's Gosport. There's a number of really high-profile cases where actually the truth has been hidden, and there's been a subsequent cover-up. Belfast hyponatremia inquiry. I was teaching on this yesterday, so all these cases are in the front of my mind. And you can get really stressed by thinking about those, and sort of. The question that the students and I were discussing is these high-profile cases are where somebody's made a really serious mistake, they've lied and covered up, and an organisation's covered up. How common is that? Is it getting better?
How do you know?
I think it is, but how do you know? That was exactly what the question that came up in the session. How do we know?
Yeah, I mean, I remember reading in James Titchcomb's book about Joshua. He got all these notes with redacted files. This was, I think, early days probably with word processing, and he knocked the keyboard and didn't know what he'd done. And of course, they tried to cover over all the letters with black redacted thing, and it all came off so you could see what they'd written about him, which wasn't great. I can't remember the full details. But I do know the 3 nurses involved. You know, they lied at the inquiry. And the judge, from reading the book, from my memory, it was a while ago, wasn't too impressed by that. And yeah, that's not good. That is exactly the culture we've got to change. Is being open to making mistakes, definitely. And I suppose as patients, accessing is to fully be understanding when mistakes happen, depending on the severity of that mistake. Because I think some mistakes, you know, understandably, are absolutely you just can never accept. Yeah, absolutely. So yeah,
generally people are accepting, but it's I think a key to changing this, and we were talking about this in the teaching session I was giving, this was with nurse and pharmacist prescribing students yesterday, is what can we change that will enable that to happen? And I feel very strongly that online real-time access to records and recording consultations.
Right. That would be brilliant. I've recently accessed my medical records and had a look through them, and I was thinking to myself, oh, I wish I'd known all this before. It was, you know, I had all the different diagnoses about me, things that happened, but trying to get hold of those notes has been, a bit of a struggle to get them. And even now, I kind of feel there must be more, because I only got sent specific letters and things that were interesting to see. But I suppose I'll cover that a bit later when we get to the different topics. So yeah, truth in healthcare, I think getting there, but there's still work to go. And I think we're getting there. And I think having people like yourself, Steve, you know, it's brilliant. It's very reassuring for me as a patient to know we've got people like yourself, you know, who really working hard to change things and leading by example. And I suppose that's why it's so important to sort of, you know, recognize that, you know. So one of the topics I wanted to bring up is a bit of a controversial one, is opioid prescribing. As you know, Steve, I've a complicated history which I won't go into, but after having a full gastric bypass after a car accident in 2008, I resisted having opioids for about 4 years until I finally, you know, accepted that to improve my quality of life, and I've then gone on to do lots of stuff since. But it's been really tough, especially in recent years. With these new guidelines coming from the CCG and nationally around opioids being used on a long-term basis. What are your thoughts around opioid prescribing?
I think the issues of, it's not a specialist area of mine, but the issues are similar to all medicines. I mean, you've got to look at, is it appropriate? Are there alternatives? But you've also got to look at make allowances for people who've been prescribed opioids in the past, and maybe now you wouldn't prescribe them, but how do you get people off them and help people change? There's been some recent guidance on long-term pain management from NICE, and it was a little bit misinterpreted in social media, because a lot of people were saying, hang on a minute, you're going to stop my opioids, is that what this guidance is saying? And It wasn't, but I don't think it was put across that clearly. NICE had to put out a statement to say this doesn't affect.
Yeah,
You have to think carefully about people who've been long-term prescribed these things. This is about new patients and what you prescribe.
well, I know my sister. She rang me up and she was like, "We're not even allowed ibuprofen now."
Yeah.
You know, and there is a feeling among patients. I've spoken to them where it's like the pendulum. Yes, opioids have been overprescribed, just like they have in the States. But there's been an overswing the other way where doctors are almost terrified to prescribe them. Patients like me that have been on them for a few years, you know, I've ended up having to change GP practice. I had my doctor retire. He was the one that put me on them and had known me since the age of 3. So, you know, it was very much done with him understanding me entirely. And it was certainly a last resort, but it really changed my life around. I've achieved so much since then, and that's working with the pain clinics as well. And I think as long as you're working with the pain clinics, it's fine. But I know one, yeah, I'll let you come in actually.
I think, as I say, it's not my specialist area of prescribing, but I think there's a bit like having access to your own records. There's something that's really important about prescribing, and it's about giving time to people. And if you only have a 10-minute consultation and you've been on the opioids for a long time and you've got real serious concerns and you want to come off, as you should do, very slowly, there isn't enough time. So you mentioned the pain clinic. I used to refer a lot of people to a health psychology clinic when I worked in a community mental health team. It's about time to get to know and understand the patient and come up with a decent plan. And I think one of the difficulties here is the lack of time when it comes to prescribing consultations. If you need them, you need them. If you want to come off them, you need to come off them very slowly. But to unpick that and work out what help the patient make a plan takes more than 10 minutes. That's why I feel for GPs are very stuck sometimes in this situation.
Yes, I mean, I've got 2 different sides. So I've had my experience with the pain clinic, which was I don't know to say where it was or not, which was in another area. Let's just say that, but err on the side of caution. And they were brilliant. As a Pacific person that I saw, he really got to know me and was like, well, you know what, if they're working for you, Dom, then you know, and it sounds like they are, then that's all good with me. And that was a great approach. I remember going with a relative, and we had a different pain doctor, and it was just right. That's it. You're coming off them all. You shouldn't be on them. And that's even with X-rays and 2 spinal fusions that had failed, bolts in the back that are free floating. The actual metalwork is starting to come away. I think it's only on by 1 screw. You know, so you can just imagine the pain. Bone on bone knees as well. That was 15 years ago diagnosed. 1 new knee. That's giving out now. But this person's terrified of even going back to hospital because of the lack of feeling in control. And there's also the anxiety as well. People who suffer with anxiety, it makes it 10 times worse. And I think there's nothing worse than having a medication that you know you desperately need, and it's sort of hanging on a thread.
Yes.
It's the worst feeling in the world. But I've actually had doctors say to me, you know, look, you know, we're worried. I'm worried I'm going to lose my license if I prescribe, you know. I mean, I think they're over worrying now. I think sometimes these guidelines are taken as almost orders, or you know. But yeah, I suppose, what are your thoughts on all that?
Yeah, I've done a little blog on that. Guidelines are guidelines. They're not. NICE itself does this slide that says they're guidelines, not tramlines. It's about the individual patient, and there's NICE guidelines on multimorbidity and NICE guidelines on medicines adherence, which are guidelines that clinicians should also follow, and that's about listening to patients. And that gives you, it's a guideline about not, they're guidelines about not following guidelines if it works for that patient. Of course, the worry, there's a lot of laws around controlled drugs, and the worry for clinicians is diversion, is if somebody's actually asking for it and they're just selling it. and that's relatively rare, but it does happen.
Okay.
So
Yeah, I've not heard of that until you just said. I mean, it makes sense, but I wouldn't imagine. I can't imagine any of the people I know would be doing anything like that.
I think it's unusual, and you just sort of know, and it's about building a relationship of trust, and it happens with other drugs too. I could go downtown now and get some pregabalin, no problem.
Really?
Or
Yeah.
pregabalin.
From the doctor, I'm assuming this is.
No.
No. Right.
In the street, I could go down and get some street pregabalin. Somebody's been prescribed that.
Yeah.
Probably. It's probably not been stolen or anything. It's probably just come from somebody who haven't been over prescribed. So
right.
You've got to, as a clinician, you've got to work out, what does this patient need? You don't want somebody to suffer in pain. You can justify opioid medicines and continuing with them even if they don't follow guidelines, and be sure not to start something that isn't actually going to work.
Yeah, I think that's a really good point there. I think you've got to have some you've got to have X-ray, MRI, MRI even. You know, I know myself, I've got multiple MRIs and that. And I've just losing my train of thought where I was going with that. But yeah, around the opioids, I mean, it's not. I think you've got to have an alternative. You were saying pregabalin. I know the gabapentin. Really didn't get on with that gabapentin. It was almost like it blocked the receptors. I was actually reading a PubMed on gabapentin, and some of the things they done. It was actually saying that it's almost like the key in a lock, that it fits in the receptor, but you can't turn the key. So then other things come along, they can't interact with the actual dopamine.
There are some, yeah, there are, and it's about having the time to understand what works, having the right skills. So if I don't work as a prescribing clinician now, but if I saw somebody who was, their medicines issue was beyond my scope of practice, my scope of practice was pretty narrow. So if it was beyond that, I would want them to see somebody else. And it's about being able to get a second opinion from somebody who knows and who specializes in that area.
Yes, I mean, I suppose also coming back to what you said about having the right amount of time to talk to them.
Yeah,
I remember when I moved from my previous GP and my new GP. I only ever had a phone call, and half my script got cut. He said, "Right, I'll take you on, but I'm not prepared to prescribe these tablets," and completely cut them. No. There was no discussion about it. It was basically, you know, think yourself lucky that you're on any painkillers, and that was a horrible feeling. But you know, since then, I think you've seen the video that I did with my mother.
yes.
You know, I've been left, and she's been left in a situation where, well, we've had to use medicinal cannabis. You know, I suppose that sort of nicely moves on a bit round to medical cannabis, and that. I was really surprised by the last time I'd used cannabis was decades ago, you know, and I wasn't taking it for pain, it was recreational. But when I had up-to-date cannabis, this is what they would technically call street cannabis, I was blown away how powerful it was, how much it did for my mother and me. And that's why I ended up joining Project 2021. Because it seemed to me, well, look, you know, if opioids are terrible and you're going to get people off opioids, you've got to replace it with something else. And pregabalin and gabapentin, I'm not fan of at all. In fact, I'm pretty sure in another 10, 20 years, we'll find something out about these new drugs that isn't that great.
I wonder, because we were having a discussion this in our teaching session, and many years ago there was barbiturates that were given out to people very commonly, absolutely dreadful side effects and long-term effects, and they're not prescribed at all. Then there was diazepam that was given out very freely. Terrible drug, really one of the most addictive drugs there is, worse than heroin, really hard to come off. You build a very, very big tolerance. I mean, we know about Valium now, and we know when it's useful and when it isn't. So what are we doing now that we don't know about?
Exactly.
That we're going to find out in the future.
when I was a child, I was on diazepam at one point. This was in the 80s.
Mm.
So absolutely. And yeah, I'm not a fan. As soon as I looked into it, I was like, look, I'd much rather stick with a drug that's been tried and tested over the years. And it makes sense to me to stick with that. And I suppose the other thing around opioids and my frustration with this is seeing what's happening in America. Where people, they're having their scripts cut. Yeah, people probably put on oxycodone, codone or codeine, OxyContin even. Whether they're rightly put on that or wrongly, then being all those scripts being stopped, they've been cut. I think by like 100 million scripts have been reduced down. I have to look up the figures and get Martin to flash them up on the screen. And it's shocking. You see the number of opioid prescribing going down, but then you see the number of opioid deaths going up. And most of those are in the community because people are taking heroin that's been mixed with fentanyl.
Yes. The pharmaceutical industry has had a big role in this in America, and there's lots of stuff about how, I mean, drugs are advertised by brand name in America, unlike in this country, and there was a lot of promotion of these drugs.
Well, absolutely. That, I've seen some of the videos, very much, give your patients this, and doctors were very much encouraged, weren't they, to give it out. And we've seemed to have gone the other way, totally gone the other way. And I just don't understand it, Steve. I just don't understand how a doctor can sort of say, right, that's it. No, you're just going to be in pain. I just don't get that.
There are very few medicines that if you're going to stop them, there are very few medicines that you can just stop. And opioids are one that you shouldn't just stop. If you're going to come off and taper it off very slow, the key thing with medicines, and people are taking a lot of medicines, is go slow. Usually when you're coming onto it, go slow. It depends on the medicine, but come off it very slowly and only do one thing at a time.
Yeah.
Don't just stop the medicine and then do something with another one. You'll never know what was the thing that had the bad effect or the good effect on you.
Well, absolutely. And I remember, going back to the gabapentin situation, I'm absolutely convinced that blocked the dopamine receptors, because it was like being on some sort of opioid blocker. I'm going around in circles there. So yeah, back to the States and the fentanyl, and I know I read articles where actually the dealers, the organized crime gangs, were actually targeting states where they were hitting the patients hard, and saying, right, this is where we're going to make all the money now. Let's put all our resources in there, and that's why we have this epidemic. And I suppose my biggest fear is, let's not repeat what they're doing over there. Please, let's not do that. Yeah. And it feels like we're heading that way. And I can tell you, if you're in agony and you're in unbearable pain, and there's a drug out there, and your doctor's not going to give it, you will end up, very close to coming on the black market. I know I did. Unfortunately, Project 2021 came along. I'm glad it did, because I was very close to trying to learn the dark net, because I didn't want to interact with people from my past. I couldn't work it out very much, and I'm glad I didn't. And I decided some of these words that somebody said to me, Dom, I know and trust you'll make the right decision. And I had those playing in my head. I'm so glad I found Project 2021, and to be able to get, hopefully, board approved soon, medical cannabis, where I'm completely legal. It's prescribed by a doctor. It's all done absolutely properly. They irradiate the flower. A lot of people call on the street, call it bird or weed, but it's actually a flower. They irradiate to get rid of mildew, pests, and other things, which probably doesn't happen with street weed.
Well, you don't know what you're getting. And also buying medicines over the internet, even sites that may look legitimate, you've no idea what you're getting. And the big danger with opiates is you build up a tolerance, so you have to take more and more and more, but that drops fairly quickly if you come off them. So and there was an alert came out several years ago, it still applies. if you're taking opiate medicines, then you stop them, or taking opiates for whatever reason, then you stop them, your tolerance will go very quickly. So if you start taking the dose you were used to, you can easily die. And the street drugs, there's a drug called carfentanil in America that I read about a year or so ago that is extremely potent, caused a lot of deaths.
Yeah, I've not heard of that one. What was the name?
It's like mega fentanyl. It's not
Wow.
but that's what people were turning to.
Yeah, that's quite shocking, because I know fentanyl is, I think it's meant to be 50 times stronger than morphine. So thought something stronger than that, that is a scary thought. And it just seems common sense to me that I actually think even addicts, they should be treated on morphine and use the same drug. And moving on, I found this out. The methadone, which is a synthetic opioid, it was actually the Nazis that invented that. Adolf Hitler, there was blockades for Germany, so they couldn't get any opium. So he went to a scientist, go and make me some synthetic opioids. So like all good scientists do, they went to make something, and they made it, last longer, more potent, also more toxic as well. And that's where the history of methadone is. And what really shocked me, I mean, I don't understand why we give people a synthetic opioid when we could be giving them. I mean, what are your thoughts on that? Why do we give people synthetic opioids like methadone instead of just putting them on morphine and reduce them down and getting them on street drugs?
As I understand it, it's not my area of prescribing, but methadone's used because you can control the amount and you can't inject it. So
right, okay.
And there's a drug called buprenorphine that's sometimes also used, and that blocks receptors so that you can't take on top of it. You can't take extra. So there's a method, the reason why they're used to try and taper people off. Different countries have different approaches. Portugal's got a completely different approach to substance misuse.
Yes, they have. That is a whole new topic after.
It is. It's not something I know a lot about, but I'm certainly interested in. Is our approach really successful, or should we be decriminalising drugs and making it safe, and thinking about harm reduction? The focus in this country with drug services shifted largely from harm reduction to abstinence. And for some people who are addicted to certain drugs, that's a very tough goal.
I don't go with the abstinence one for a multitude of reasons. I think mostly because I've met people who have used drugs like that, and they don't use them for no reason. They have a very traumatic past.
That's it exactly.
And I know that traumatic pain, psychological pain, has a physiological response. And I actually think emotional pain, I've experienced emotional pain that's almost as bad as physical pain.
Yes.
And I think there's been some studies on that. And I suppose, sort of moving on, which I meant to say earlier, was what really shocked me was I saw opioid patients being reduced down and sent to pain clinics. There was a documentary, I think it's Panorama, some years ago now, where they actually had people who'd been prescribed morphine were actually putting them on methadone and treating them like addicts. And I remember when I went with my relative to the doctor, they actually said, "Oh, we need to send you to the community drugs team." And I'm like, I'll just be honest, it was my mother. And I'm like, "What? You're not sending my 75-year-old mother to the community drugs team?" Yes, I know anybody can be an addict, but that was completely wrong advice.
There's got to be a better way of doing it than that.
That is not the thing to do, sending 75-year-old to there, and certainly not putting them on methadone either. That I found very alarming. But I don't think I've only seen it on that one documentary. But it needs sorting out, and I suppose that brings us on nicely to our fourth topic, because we're coming up nearly on time. And that is medical cannabis, which we kind of touched on a bit. Why on earth are we not giving people medical cannabis when we've got this plant available that's really good at pain relief? We've exploited the poppy with morphine, the pharmaceutical companies have. Why haven't they exploited the cannabis plant?
Mm. I mean, people might say, again, it's not my direct area of expertise. People might say, well, actually, this isn't a manufactured drug made out of a molecule that somebody can charge a lot of money for. That's one argument. In the My Medicines course that I do, our basic philosophy is we don't care what people choose to do to help them if it works and it's safe. And I think that basic principle should apply to medical cannabis. I know there's a lot of reluctance to prescribe it, or apparently there's a lot of reluctance to prescribe it, which I'm not.
Yeah. Well, I'm accessing mine through private script. I can only everything's unlicensed at the moment. It's a bit complicated because I know Hannah Deacon with her son Alfie, who has seizures, up to 200 seizures a day. I know he's on the NHS script, but he's only one of 3 children, I believe, on a script like that. I know she's doing some amazing work, but shout out to Hannah. I suppose I actually met her at the Hemp and CBD Expo right before lockdown, actually. And it really opened my mind to medical cannabis. And when I saw Dr. Danny Gordon giving a talk about treating, people with psychosis, I'm like, hang on, what? Psychosis? You can't cannabis, like this doesn't make any sense. And she was explaining using CBD, which is an antipsychotic. And it just blew my mind. I'm like, how did I not know this? Yeah.
Heroin has antipsychotic properties. So you talk about people living traumatic lives. It's, from my point of view, and I don't claim any expertise on medical cannabis or anything like that. But as I say, my range of prescribing is very small. If it's safe, it's worked, it's legal, it's from a reliable source, you know what you're getting, that takes away a lot of the problems. When people talk about medicines being unlicensed, that's a bit of a red herring because a lot of medicines are prescribed unlicensed regularly.
Right.
For ordinary things.
And the other thing I've been told is that doctors say to me, oh, well, I can't get insurance. Insurance companies threaten me if I prescribe it. I know I heard Hannah in a webinar once saying that actually in the last 3 years with children, we've had backward steps, which is disappointing to hear, especially when I've seen what good it does. From 200 seizures a day down to 5 to 6 a day. It's not a cure-all, but my goodness, that's a massive drop.
That's sad to hear. It's an insurance issue, and that's sort of worrying, isn't it?
Yeah, I think there are other issues as well, which I'm not privy to. I would love to know. So shout out to people, get in touch at official Dark Jedi at gmail.com. Any doctors out there who want to enlighten me, that'd be great. Go on, Steve. I can see.
I'd like to learn too. Yeah, what are the issues for prescribing it? Is it fear of the unknown? Is it possibility of getting sued? Is it insurance? I don't think it's because it's unlicensed. Because, like I say, if you prescribe, as a prescriber, some of the medicines I prescribe are unlicensed. Some of the ones for bipolar disorder. That's fine as long as you've had the conversation with the patient to say, this is not licensed for this condition, but it's widely used. This is what you might expect from it. This is the reason it's not licensed, which is sometimes because nobody's got around to, the company doesn't bother to license it. There's not always a medical reason. Okay. I'd really like to know, to understand what the issues are about prescribing medical cannabis, all the issues, and maybe that will help promote a safe growth in something that's potentially good.
Yeah, well, absolutely. And I suppose I better mention some work. So the Medical Cannabis Clinicians Society, I think it is, or group, and drug science as well. And I know drug science part funding project 2021. So getting 30 grams of flour, and this is proper high grade flour that's completely dry, so you get a very good money's worth, and it's just £150 for 30 grams. And I hear that on the street, that would be about 170 all the way up to 200 and something. So that being subsidized, I think is a brilliant move. However, that is still out of reach of a lot of people. Yes. And on the long term, me affording that, it's a massive amount of money for me.
Well, a lot of people, it's very difficult. Yeah.
And what I am keen though is what I am pleased about is to try and change the stigma. And I found a video the other day. I don't normally retweet videos of people with cannabis, but this was done properly. I don't know whether you saw it or not, but
No, I
it
don't
was
think
an
so.
unboxing. Somebody on Medical Cannabis on the project, and they unboxed it, and you could see the pharmaceutical bag. I'm sure there was like Lloyd's pharmaceutical bag or something like it was you very clearly a pharmaceutical bag. They did the unboxing. They did a review of it. It was very professional, looked very good, and yeah, I put that out there. It's only a 2-minute 41 video, but I found it helpful just to understand it. But it's all clearly marked out. You're prescribed exactly the right amount of THC versus CBD. I've been prescribed 30 grams of flour of different types, so 10 grams of different types of flour. So that's 3 different types because they all work differently. You have sativa and indica. Bear in mind, I'm just picking all this up, and they work differently. For pain, evidently, the THC is a lot better for pain. I think that's the indica strain. But the interesting thing out there is there's all these flowers, but they all work differently with different people. So I kind of feel we're sort of doing a bit of trailblazing, and working things out. So hopefully, eventually, we can get it approved by NICE and on the NHS. But at £5 a gram, which it is at the moment, sometimes more, can you see it getting prescribed on the NHS or NICE approving it at that price?
Are there good clinical trials going ahead? Problem with clinical trials is a lot of them have influence from the drug industry, but what you need is to get it to NICE's methodology for assessing something is they always stick to it. They're very consistent, and it's very much based around clinical trials and the quality of the evidence.
Right. Okay. Yeah.
That's what will get it.
Well, I know with Project 2021, the idea of the project is to get up to 20,000 patients. At the moment, the records just came out today, actually. So we've got 900 people officially on, but that list is growing. It seems to be more men than women, which was a curious one. But the results have been really positive, and that's all being recorded. And this is another reason, if you can afford it, get on Project 2021. Absolutely. You'll be helping further the cause. You'll be helping people like maybe your grandmother, well, even yourself. You're going to get arthritis one day. You're going to get a bad back for one day. So, it seems crazy there's medication out there. I would like to recognise, though, at the same time, I have a very good friend. I won't say his name, but relative of his, smoked street cannabis and ended up with psychosis and taking his own life. So I don't want to downplay that side of it, but as long as it's medically prescribed and done properly, it absolutely should be a medicine we should be using, 100%.
Then the evidence, clinical evidence on that will be critical to getting it into the system. And it's so important if you're going to take something, you know what it is.
Yeah, absolutely. And I think that's what I'm really pleased with. You get a formulary of different flowers. You can pick the different CBD ratios. It's all marked on the packages from what I've seen from other people's. Mine's not come through. I'm not board approved yet. Hopefully I will get the board will approve. I'm expecting this week. I've had the script written out, but until it's properly approved by a multidisciplinary team, there's a lot of regulators. It's taking me ages, frankly. It would have been easier for me to pick up probably. Or from the sound of it, give you a call.
Yeah.
So, Steve, we're talking about medical cannabis. Let's pick up there. We had a bit of a technical issue. So, yeah, medical cannabis. I get it all listed out what I'm prescribed. And then they've got me on 10% THC, 10% CBD oil. So I've got a bottle of that coming as well as the 30 grams of flour, so I can experiment and try different ones, see which works for me. And I'm really looking forward to getting to it. I think it's the stigma. I think that was a big part of it. I know one GP who I referred to the information, the data, but just did not want to know. That was on social media on a public platform. So there might be concerns there, which I can understand, of people coming to the wrong assumptions or judging them. How do we get past this stigma? How do we get healthcare professionals to get past the stigma that the drug carries.
It's difficult, isn't it? Because it's what you're describing is a drug that is regulated, legal. You know what you're getting. You know what you're expecting to get from it, so you'll be checking that. It's being tested on a lot of people. I think it's interesting that the messages around this that are important. This is something potentially useful that is following all the best practice standards that other medicines follow. And eventually, if there's a good controlled trial, it sounds like there is a good trial that meets the NICE criteria. This is so important to get it into a NICE guideline, is that you've got good top class controlled trials and lots of evidence.
I'm pretty certain it's very official. I know the people involved in it, and they Mike Barnes, Dr. Danny Gordon. I don't want to carry on names because I'll miss some out. So I'll just stop there. But it's being looked at properly. I know with the various governments have been looked at it. So I have every confidence. I just think we're struggling. I was really surprised we only had 900 people. So we really need to get those numbers up, because if we can get even 10,000 people, that is a really good control sample then to go to NICE with. I suppose the other thing is driving the price down as well, which I think will happen. I think it used to be extremely expensive before. I know it's come down. I mean, for me, coming in new, I was like, wow, this is expensive. And people are like, yeah, you should have seen what the prices were just a few years ago, Phil. So yeah, I definitely feel like I'm doing my bit. I decided to be a bit more open about it on Twitter, which was a big move for me, because I actually work with some drug charities and that. But things are never simple in life, are they, Steve?
No.
You know?
The best things are worth fighting for.
Yes. And this is definitely a hill I'm happy to die on. Now I've understood what it does prior to using it, and then deciding to use it and going legal on it, getting it legally. I'm hoping actually to get my mother on it, but I'm going to see how I get on first, because one of my biggest fear was, well, what if the GP now says, right, you're on this medical cannabis, you don't need any of your opioid medications? So it's quite a scary thing, and I don't think doctors or healthcare professionals always understand the fear that it induces, because this is a drug that, whether it's opioids or medical cannabis, they have helped me get to this point. I do have my criticisms of opioids. Absolutely, it does give you brain fog. It does zap your motivation. And I'd much rather be on medical cannabis. And that was another reason as well. Is I would be a lot happier off opioids. And I'd love to be able to interview you next year and be like, Steve, I'm off opioids now. I'm just using medical cannabis, and in 5 years' time, they're going to get on the NHS. I do think we're moving that way, and I do hope we do move that way.
Well, that would be good to do that. Let's hope we can do that, and look at the benefits that brings for everybody.
Well, absolutely.
The people private, other medical professionals you might see, everything that's involved in.
Well, I think the stigma is going to be the first part. And I suppose that's where people like yourself come in. We need people like yourself, healthcare professionals, that aren't afraid to talk about medical cannabis, aren't afraid to ask the questions, and be open about it on social media. I think there's a lot of misconceptions. It's really unfortunate. But yeah, it's absolutely something that needs to change. And I know my friend Ryan, I'll give him a shout out. He's just set up a new organisation. First of all, we've got PLEA, patient-led access, and I can't remember the rest of it. And we've got FAFA as well, which is fair access for all. A bit like FIFA, but with an A. And Ryan's, we're just in the process. He's set up FAFA. I've joined in. we're getting that sorted, because we absolutely believe in fair access for all, and it doesn't seem right. He's on 46 medications, and now he's down to only a few. I can't remember exactly, as I don't want to misquote him, but 3 or 4 medications now. And he's worried about his liver and his organs, because he's had tests back. And what seems crazy is that if he can't afford it, he's putting it on his credit card. He might end up having, if he can't afford it, to go back onto all these meds he's just got off, which seems crazy. So I really hope things move along.
It sounds there's so many benefits. I mean, once you're taking more than 4 medicines, it's almost impossible to work out what the interactions between those medicines are, what all of them are, and what possible adverse effects are coming from what. Once you get over 4, so anything that reduces the overall burden of medicines that people are on has got to be a good thing.
Absolutely, absolutely. I couldn't agree more. And I think it also depends on the quantity of medical cannabis you use. I know some people, I've read about them taking tolerance breaks. And I was reading a study where just after 3 or 4 days of a tolerance break, your tolerance drops significantly. So then the drug is more effective. I mean, I wonder how many drugs, that we're prescribed now, work in that way. I know amitriptyline, which is something I've been on long term. Whenever I've tried to reduce that down, oh my goodness, that's not seen as an addictive drug or anything, but trying to reduce it down, it makes you feel terrible. I mean,
it builds up in your system. It's got a long half-life. I know. In some cases, people, when they're in hospital, they're given drug holidays to try and work out it's like a tolerance break, I suppose. But
right.
Yeah, sometimes
it builds up a picture in the mind.
Yes, I mean the holiday from drugs. But again, you've got to do things really sensibly and in a measured way, so that you can work out what it was that actually gave the good effect.
Yeah, totally. And that's it. If you're on multiple drugs, how do you know which one's doing what? And I don't think that goes on enough. I don't think I've ever done that with my doctor or GPs over the years. I don't think we've ever really done that. I've always been on some type of drug. Yeah. Sorry. How are you? Is there anything more you want to add to that?
No, I hope that was useful. I'll be really interested to hear how things get on, and I really appreciate the opportunity to share my views.
I'm really glad to have you on Dark Jedi, Steve. And as I said, Martin will put everything up. And thank you for coming on.